I hope I'm audible as well.
Yes, you can.
Okay, so let's go to this topic, HPV vaccination. But before I go to the details about the vaccination, it's important to know burden of the disease, cancer cervix. As per GloboCan 2018 statistics, cancer cervix accounts for about 600,000 new cases every year and about 300,000 deaths occur in the world because of cancer cervix, which translates to about 8% of cancer deaths among women. What about in India? It's the second most common cancer among women in India, and it's also the second most common cause of cancer deaths, and which is higher than when compared to many of the other countries. In fact, India and China tops the list of cancer cervix cases as well as deaths. For an Indian woman, the lifetime risk of cancer cervix is as high as 2%, and about 60,000 women in India die every year because of cancer cervix, which translates to about 200 women every day. So that is the burden for us. To put things in perspective, let us look at what's happening in countries like the United Kingdom. So there, about 9 women are diagnosed every day. Around 3 women die per day because of cancer cervix, which translates to about 1,000 deaths per year. So why this disparity? We all know that HPV is ubiquitous. It's one of the most common sexually transmitted viral infections. The lifetime risk for acquiring infection with HPV for any one of us, is about 80%. But it's also true that 80% or more amongst us will eventually clear the infection because of our immunity. So it's found that natural infection with HPV does not always induce a vigorous immune response because the virus is restricted to the epithelial layer of the mucosa, and also because the immunological response varies from individual to individual and also depends on which HPV type you have got. Generally, because of a good cell-mediated immune response in most of us, it's cleared, and even if some mild lesions do occur, they tend to regress. And as mentioned, in about 10 to 15%, infection with high-risk HPV types, and also because of the presence of certain cofactors, the probability of progression to persistent infection is more, and therefore cancer develops in a very few percentage. We know that out of about 120 known HPV types, only 12 to 15 are considered high risk for HPV because they produce carcinomas of the anogenital area as well as oropharyngeal areas. Having said that, 16 and 18, the types 16 and 18 on its own accounts for about 80% of cervical cancers. And if you take 4 or 5 others, then altogether this causes more than 90% of squamous cell carcinomas of the cervix. And 99.7% of cancer cervix is produced by one or more of the 12 high-risk HPV types that I've put up on the slide. Now, why is it that the prevalence of HPV infections, cancer cervix deaths and cases are so less in the Western world? Is it because there is no HPV there, or does the prevalence of HPV differ? No. It's found that HPV 16 is the most prevalent HPV in all regions and all continents, including India, followed by HPV 18, whereas the other high-risk types have almost similar prevalence. It's also found that a woman who's infected with one HPV may become co-infected or may be co-infected or subsequently infected with any of the other high-risk or low-risk types. So then what is the difference between countries like the UK and India? So let's take a look at this chart, at this slide. And this is the story of why countries like the UK have been able to bring down the number of cases and deaths. It's not because they do not have HPV. It's because they've started proactive screening for early lesions as early as the 1960s. And the government there instituted a national health cervical screening program. As part of the NHS, they have a national cervical screening program, which was started formally as early as 1988. They've also switched to more sensitive and specific detection screening tests and diagnostic tests, including liquid-based cytology and now HPV DNA. And as you can see, as early as 2008, they also set in motion a national HPV vaccination program. In fact, in 2019, this vaccine is also being given to boys aged 12 to 13. So this is, in a nutshell, why the cases and deaths are so less in countries like the UK compared to us. What about India? Do we even have a national screening program? Not really, and it's not exclusive. Yes, we do have a combined program for the prevention and control of cancer, diabetes, cardiovascular diseases, and stroke. And 3 cancers are included: oral, breast, and cervical. And VIA, which is chosen as the main screening strategy for India, unfortunately, is not that sensitive or specific in picking up early lesions. And so these are some of the drawbacks of the screening program or the lack of it in India. So then WHO recently, a year ago, has come up or has called for an elimination strategy. They've said that enough is enough. We need to pull up our socks. And what do we need to do, according to the WHO, to reach the elimination threshold of 4 cases of cancer per 100,000 women a year by the end of this century? Countries should achieve the following targets. And this is the targets by the year 2030. It's called the 90-70-90 targets. And the first 90 is 90% of girls under the age of 15 should be fully vaccinated with the HPV vaccine. Of course, the 70 stands for using a high-performance screening test like HPV. And the other 90 is once diagnosed, 90% of them should get effective treatment, so that in the long run, about 30% reduction in deaths due to cancer cervix can be achieved. Now, it is not really even 30%. We should be aiming for no deaths due to cancer cervix, if that's possible. Right. With this background, let us look at the vaccines available to fight against cervical cancer and the precancerous lesions of the cervix. So it was The development of the first vaccines, the credit goes to these Australian and American scientists. They used recombinant DNA technology. They used purified L1 structural protein of the virus, and it contains no HPV DNA. Remember, the vaccines do not have any infected material, pathogenic material.
Okay.
It only contains virus-like particles, which are purified structural proteins, or which produces a resemblance immunologically with the virus and therefore induces type-specific antibody. So it is this major capsid protein L1 of the virus which is presented to the immune system. And what does the immune system do? When it's presented as a part of the vaccine, it is effective in eliciting not only a cell-mediated immune response, but a humoral immune response as well. And the serological response after vaccination is found to be stronger and also longer lasting than when you get a natural infection. This is, I believe, this is the mechanism which we are all aware is happening with the COVID vaccination as well. And it's also found that when you're vaccinated, you also get partial cross-resistance to non-vaccine related serotypes to the order of 30 to 60%. So a little bit more about why the vaccine induces more immune response than a natural infection. There is a better activation of the lymph node cells by vaccines than by natural infection, maybe because of the use of adjuvants in the existing vaccines. The long-lived plasma cells continuously produce immunoglobulin antibodies, IgG, and immunization also elicits memory B cells. So it remains in our immune memory. What are the vaccines available? There are 3 types: bivalent Cervix by GlaxoSmithKline Beecham, which was FDA approved in 2007. It's bivalent because it acts against type 16 and 18, which I mentioned accounts for almost 75 to 80% of cancer cervix. The next is Gardasil, the quadrivalent type, which also has protection against 6 and 11, which are believed to be low risk HPV types, and therefore protects against not only cancer cervix, but also anogenital warts. And the latest one in the field is Gardasil 9, the nonavalent vaccine, which acts against 9 types of HPV. So let us compare and contrast the 3. As I mentioned, bivalent against 2 high-risk HPV, quadrivalent against 2 low-risk and 2 high-risk, and nonavalent against 2 low-risk, and all the others are against high-risk. And this is the antigen expression system used. East is the one that is used in the quadrivalent Gardasil and in the nonavalent Gardasil 9. Adjuvant used is alum in quadrivalent and nonavalent. You need to store it in 2 to 8 degrees Celsius in the door of the refrigerator. It should not be frozen, and you have to give it as an intramuscular injection in the deltoid to get a good immune response. The dose is about 0.5 mils. The schedule is important. So it's a bit different for if the child is under 15, the child only needs 2 doses at 0 and 6 months interval. But if the child is above 15, then she needs 3 doses. And if it's a bivalent vaccine, you need to give it at 0, 1, and 6 months. And if it's a quadrivalent vaccine, it's 0, 2, and 6 months, which is also the same for the nonavalent vaccine. So the added advantage of giving vaccines is not only protection against cervical cancers, but also against vulvar cancers, vaginal cancers, anorectal cancers, and also warts and papillomas of the larynx. Now, what about a choice of vaccine? Which vaccine to choose? It's all been studied, and the general consensus is the safety, efficacy, and effectiveness of all three are comparable. And there's been various trials, including one in India, to come to a conclusion regarding how many doses are needed for under 15s and above 15s. Remember, even if the child is under 15, but is immunocompromised, then she will require 3 doses, just like for above 15 years. And why only 2 doses? Again, studies have shown that under 15, or rather by between 11 and 12, that is the time when the immune response is maximum. So preteens have a higher immune response to the vaccine than older teens. What about if your daughter or your child has crossed 15 years, and up until which age can you give? So the recommendation is you can give it till 26 years, though technically or theoretically on paper, it can be given all the way up to 45. But between 26 and 45, the decision to take the vaccine should be an individualized one after discussion with the caregiver and after risk assessment on an individual basis. So the ACIP, which is the first Advisory Committee on Immunization Practices, advocates that be it a bivalent or a quadrivalent vaccine, the girls between 11 to 12 years should get 2 doses, at least 6 months apart, but not more than 15 months apart. And yes, it can be given to boys also, but the policy of vaccination for boys differs from country to country. And as mentioned earlier, for immunocompromised, the dosage is 3. Now, the vaccine safety meetings, the latest one was in 2017. And according to their report published in 2017, no new adverse reactions have been reported around the world. Local reactions and some fever, headache, and dizziness, some joint pains, which are all mild and self-limiting, can be expected. Few episodes of syncope, which on analysis proved to be anxiety or stress related, have also been reported. Anaphylaxis is very rare, only about 1.7 per million, which is comparable to any other vaccines being used. What if the vaccine has been given inadvertently in pregnancy? It is not an indication for termination of the pregnancy because there is no teratogenicity reported or found with Hpv vaccination. What about some scares of autoimmune disorders, which was in circulation at some points over the past decade. So WHO has gone into the matter. They've done a lot of study and analysis, and the consensus now is there is no increased risk of any autoimmune diseases, including Guillain-Barré syndrome, with HPV vaccination. And there is also no causal association found with complex regional pain syndromes or postural orthostatic tachycardia syndrome or premature ovarian failure. And this is from the Global Advisory Committee on Vaccine Safety. So there is no real grounds for any of these misconceptions. What about co-administration with other vaccines? Including live as well as non-live vaccines. Yes, you can safely co-administer any live or non-live vaccinations with HPV vaccines, including the COVID vaccine, as long as you use separate syringes and use different injection sites. It's been found that it does not affect the efficacy of the vaccine at all. What are the contraindications for using the vaccine? As for any other vaccine, history of severe allergic reaction to the vaccine or its components, if the child is having an acute febrile illness, and if you know that the person is pregnant, also it should be avoided. So in pregnancy, it's considered a category B vaccine as per the FDA, and you need to avoid it. But if it has been given inadvertently, you don't need to advise a medical termination. And if one or two doses has been taken and then the woman conceives, then you can withhold the third vaccine or the third dose and take it after delivery. Breastfeeding is not a contraindication for HPV vaccination. In fact, it is one of the opportunities where you can actually speak with the lady regarding acceptance of HPV vaccine. So as mentioned earlier, immunocompromised persons can also receive the vaccine, but they need all the 3 doses. And it is not necessary to screen for HIV or HPV infection prior to vaccinating. At present, HPV vaccine is part of the national vaccination program in over 80 countries. And you can take a look at this slide. And in fact, you can see countries like Bhutan. Yes, countries like Bhutan is on the list of countries giving this vaccine as part of a national program as early as 2010. And also countries similar to us in economical status like Brazil, as well as South Africa, are also giving it as part of their national vaccination program. There have been some strides in India as well, in Delhi, Punjab, and some states, but we are still waiting for a true national program of vaccination, or rather to include HPV vaccination as part of the universal immunization program in India. In fact, more than 10 years after introduction of the vaccine, global HPV vaccine uptake remains slow. You will be surprised to know that even some developed countries like Japan are not promoting the vaccination, probably because of some scares and misconceptions which cropped up in the past decade. And this is mainly because of ignorance and misconceptions, which need to be removed by educating them. And unfortunately, it is countries like India that are at maximum risk for cervical cancer that are still that have still not included vaccination as part of their national program. What are some of the challenges that we face on the ground? It is perceived by a lot of parents, including educated ones, as a vaccination against a sexually transmitted infection. The others are that healthcare is not always a top priority for certain individuals or even for countries. Yes, there may be resource constraints for certain nations, including India, but is resource constraint really the reason? Because if a country like ours can send people to the moon and do a Chandrayaan mission or Mars missions and all that, which requires such a lot of money, then surely we should be able to allocate resources to prevent our women, our mothers from dying. Now, these are pictures of a very good initiative that the Thrissur Gynecological Society undertook recently, wherein the gynecologists of Thrissur Society actually took their daughters to get vaccinated. And this we did it in Government Medical College Thrissur under the aegis of the Kerala Federation of Gynecologists and the Thrissur ONG Society. And this actually had a very good response because a lot of our undergraduate students and postgraduate students also joined in getting vaccinated. And to conclude, in some parts of the world, the lifetime risk of developing cervical cancer approaches 1 in 25 to 1 in 50, where there are places where the incidence figures matches those for mortality. Why? Because there is a total absence of healthcare facilities to deal with the problem. Lack of surgeons, radiation, palliative care, so much so that women suffer undignified, frightening and painful deaths with repercussions for family and society. So prophylactic HPV vaccination could potentially save millions of lives given the necessary political will and support to overcome the barriers of cost and vaccine delivery. So it is imperative that prophylactic HPV vaccines are made affordable and accessible to those most at risk. Thank you. Thank you for your patient hearing. Over to the chair. I'd also like to take this opportunity to thank the President, Dr. Joy Manjila, Vice President, Dr. Gopi Kumar, and Dr. Sharmila, Chairperson, WTW IMA Thrissur, for this kind opportunity. Thank you.
Thank you, Dr. Megha Jayaprakash. That was an excellent presentation, and you very clearly illustrated the benefits and the need and the age group and the toxin safety profile about cervix carcinoma cervix vaccination. And we also appreciate that the guest by Thrissur Gynecology Group by encouraging, by giving vaccine to the faculty children. This is a great encouragement and moral boost and strong support to the public that when we come forward and ready to vaccinate our children, that will be a great motivation for the common public to undergo to give vaccine to their children. Okay. So now we will have a discussion regarding this talk after the end of next talk. Okay. So meantime, we will move into the second talk. Now, Dr. Dinesh is, believe he, sir is ready with his presentation. And Dr. Dinesh is one of the senior most oncologists in Kerala. He has more than 32 years of experience, and he was head of department in Amrita Institute of Medical Sciences, and now he is heading MVR Radiation Oncology Department in Calicut. Over to you, Dinesh sir.
Thank you, Dr. Joman Rafid. First of all, apologies for the change in the order, but I think that was better in a way because it was an excellent talk on HPV vaccination and the issues dealt very well by Dr. Megha. And thank you, Dr. Megha, for chipping in. And you have made my job easy because I need not repeat many of the slides I have prepared, and I would try to reduce the duplication as much as possible. But before I begin, I should thank the IMA Thrissur, especially Dr. Joy, for giving us the opportunity to meet you all in this pandemic times, because we all go through very distressing times, and meeting people through the online webinar is the only option these days. And nevertheless, it is great to meet you all on World Cancer Day. And World Cancer Day is celebrated every year. And this year it's quite interesting because the World WHO has taken up how to close the gaps in cancer care, how to remove the inequities in cancer care. And that is a theme for this conference, for this World Cancer Day. And it's very appropriate to take this topic in relevance to cervical cancer. Because cervical cancer is one of the most wonderful diseases which we can address to eradicate, because it's a disease which, you know, the etiology, you know, the long natural history, you know that, you know, a lot about this disease at the molecular level. And you've got years of experience managing this disease, right from, you know, the last 4 or 5 decades when we started treating cervical cancer. And it's very easy to treat also, because it has its own challenges and its own merits also, because the anatomy of the pelvis is so good from the radiation oncologist point of view to deliver the radiation and treat it in a great manner. So I feel the challenge before us is how to use the best of our resources to contain the disease, to prevent it. And if at all we get the disease to pick up in early stages, probably in the pre-malignant stages, and ablate it, or if you get in the early cancerous stages, to use the right modality, to create the least financial toxicities and get the maximum outcome. I think that should be our aim in all respects. Can I share my slide, Jomo?
Yes,
Yeah,
please,
you
sir.
can share.
Okay. How do I do it?
Sir, there is a screen share in the center of your Zoom window. Yeah, you just.
I think I got it.
Green color. Green color share screen.
Green colored. Yeah, that would.
Okay.
Slide desktop ഇട്ടിട്ടില്ലേ? PowerPoint desktop ഇട്ടിട്ടില്ലേ?
It is there. It is
അത്
there.
open ചെയ്യാൻ.
That's already open.
Share screen green.
Allow Zoom to share you. Okay. Okay.
Share screen അല്ലേ press ചെയ്തത്?
Yeah.
It should come. Any problem?
In the desktop, they're asking for a preference because first, this is a new system for me.
Asking for it?
System preferences.
Dr. Jaman, can you help me?
Sir, you want to send it? You want to mail it to me? I can share it from my screen. I'll try. Or what you're seeing, sir?
Actually, when I click the share screen,
yes,
it is asking for system preferences.
Yes, the system preference.
Multiple participants can share simultaneously.
Yeah. Or single participant.
Advanced sharing option, should I go for?
Multiple participants, you click that.
Oh, okay. that is clicked?
What you're seeing now, sir?
Or who can share? Only host. Can you change it?
Co-host.
Okay. I think, Joy sir, there is some system set up that only host can share the screen also. So that has to be.
Yeah, all participants can you?
All participants has to share the screen. That has to be
1 minute.
activated for him.
അതിന് എവിടെ പോവാ? Where I have to go? Screen share ലാണോ പോവാ? 1 minute. Let me see. 1 minute.
Enable screen sharing will be there, sir, for participants. That option will be there now.
Participants. Okay. I'm adding co-host. Hmm, 1 minute. Hello.
Hello.
Yes, I'm here.
1 minute. One minute. Your co-host already, you can share the screen.
Dinesh sir, I think he has rectified that, sir.
Okay. I'll try that.
So once you click there, you will get a window asking for share the screen.
Okay.
And you select the screen which you want to share.
Okay.
You only need to do the select the screen which you want to share. And then just press the button share. It will be shared.
Or I will make him host all. That will be better. One minute.
Not able to figure it out.
Is it coming?
Sir, I think you can start your presentation, sir. It's okay.
I can just verbally say it without the slides.
Yeah, sir.
I think that's better.
Yeah.
Okay. I think I can talk without the slides, and when it comes to inequity, it refers to an uneven distribution of resources. It means an unjust, avoidable differences in the care and or outcomes. Closing the cancer care gap isn't really about simply providing everyone with equal resources. It is not a case of one size fitting all. Equity is about giving everyone what they need to bring them
Dr.
up to the
Dinesh,
same
sorry
level.
for the interruption. Can you send the PowerPoint to Dr. Jamon?
I can do that.
That you do it, so that he can share it. Because since Dr. Maga can do it, it is something wrong with your system. I mean setup. That's it.
I think I apologize for that.
No problem.
Okay. Because it's the first presenter has covered mostly everything. I just have to say a few things only, especially about tertiary care.
Or you can, can you, mail it to Dr. Jamon?
Okay.
You find it difficult, then you carry on, no problem.
I can make it informal.
Okay, no problem. No problem. It's left to you.
I'll take up the questions towards the end.
Okay. You keep talking without slides, no problem. Without PowerPoint, you can carry. Go ahead.
Okay. I think I'll just talk extempore. That is better without the slides. So
Yeah.
I think closing the gap in cancer care is the greatest priority, and there is an equity gap which is costing lives, and the gap affects everyone. And how do we close the gap? And that's the question we need to address. And the issues of treatment can be addressed at three levels. One at the socioeconomic level, access to primary and secondary prevention, and access to tertiary care. And these are the three levels of challenges we have. So from the what I would try to discuss with you without the slides is how, as a tertiary care provider, how we can actually bridge this equity gaps when it comes to managing cervical cancer. As you know, cervical cancer is managed with surgery, radiation therapy, and chemotherapy. And the optimal choice of all these three modalities depends upon the stage of the disease. And once you diagnose the disease in early stages, the choice of care becomes a choice between surgery and radiation therapy. In early stages, the results of cervical cancer treatment are basically the same, whether it's surgery or radiation therapy. So how do we actually use the correct modality? And that is the question we need to ask. So if you do surgery for an early stage, the outcomes, even though are the same, certain post-operative prognostic factors would decide the second step of care. The high risk factor would decide whether the patient would go for a post-operative radiation or whether he can be kept on close follow-up. So this creates a real confusion, and the cost of care would escalate when you combine two modalities of care. So selecting the patient optimally for the right treatment is of paramount importance to minimize the cost of care. And how do we wisely choose which modality would prevail over the other? And for that, we need to accurately stage the disease. A good clinical examination. If in the clinical examination, the parametrium is involved, the patient will not go for a surgery. And if in the clinical examination, the parametrium is doubtful, the patient will have to go for a good imaging. And the current status of staging requires MRI as a modality of staging to choose whether the patient can go for surgery or not. So the FIGO has come out with a good MRI staging protocol, which enables us to see whether the disease is actually confined to the cervix, whether the endocervical stromal ring is broken, the parametrium is invaded, or if there are any nodes which are enlarged in the imaging. So in the current staging protocol, the size of the tumor is extremely important. Earlier, we used to classify as stage 1 as stage 1B1 as less than 4 centimeters and stage 1B2 is more than 4 centimeters. But in the current MRI staging, I have subclassified into stage 1, B1, B2, and B3, where B1 is less than 2 centimeters, B2 is 2 to 4 centimeters, and B3 is more than 4 centimeters. So this enables us to categorize the stage 1 into 3 levels, stage 1, B1, B2, and B3. Why is it important? If it is stage 1, B2, that is if it is more than 2 centimeters, the probability of involvement of the lymph nodes and the probability of lymphovascular invasion or deep stromal invasions are all scaling up. So if you look at the actual stage, if the nodes are involved, it becomes stage 3, C1, a real jump from stage 1 to stage 3. So that's the importance of doing an MRI in the current staging protocol, so that you can accurately stage a disease, whether it's stage 1, whether it's a low volume disease or a high volume disease. A high volume disease would lead to more of poor prognostic factors like lymphovascular invasion or deep stromal invasion. So that would necessitate the need for postoperative radiation. So the bottom line is, if you don't select the case properly, it could result in the treatment going from a surgery alone to surgery with postoperative radiation or chemoradiation. So that's the problem with not using the right staging tool in modern treatment algorithms. Jomon, I'm audible?
Sir. Yes, sir. You're
Yes,
audible.
sir.
Very clear.
Yes, sir.
Please carry on.
I think in the interest of time, I think we can take some questions which you can ask so that I can, answer them, so it will be more interactive. Since you're quite aware of the problems, and as a radiation oncologist, you are well versed with the issues, I think we can make it interactive. Otherwise, without slides and without the silence of the audience is a bit stifling for me also. Okay. So as I was mentioning, the staging is extremely critical in seeing that we adopt the right treatment strategy for various stages of cancer. And the radiation treatment has also changed over the years from the earlier treatment of a simple cobalt treatment. We have moved over to linear accelerators, and imaging has been very critical in the modern treatment strategies, because with a good imaging, with the modern linear accelerators, you are able to conform the treatment in a nice manner to adapt your treatment plans to the required volumes, and that way we can minimize the toxicities. So a great deal of advancement have occurred in the technology also, wherein in the treatment of cancer cervix, you can minimize the bladder and rectal toxicities to see that you improve the therapeutic ratio to get better outcomes. So that is the the main challenge we have in reducing the toxicities from combining treatments. So choosing the right stage and the right modality to treat the disease in the correct fashion is the main focus in modern times. the radiation oncologist also has got the advantage these days with the changing technologies in the brachytherapy systems also, where we have from an era where we used only low dose rate systems, we have the advantage of using high dose rate brachytherapy treatment protocols, where the patient's treatment can be minimized and you can avoid protracted treatments for long periods of time. And you can treat these patients as outpatient with precise radiation therapy, which is image guided and focused to your treatment volumes. So that is another advantage. But all these increase in technological advances has its own economic consequences. So to bridge the gap, to bridge this inequity gap, I think we need to select the cases rightly for which modality we want to use and which planning we have to undertake. Sorry, I got the Jomon.
Yes, sir.
You can guide
Audible.
the talk. You'd be able to chip in with some of the questions you have, or can we move on to the question answer sessions, which would make it more interactive?
Okay, sir. We will make it more interactive, sir. Okay. Thank you for your excellent presentation, sir. Unfortunately, we couldn't see your slides. That's what I feel, because you are talking from a very deep experience. So I know you will have a lot of things to share. Okay.
Yeah, I'm sorry about
so
that.
we will start our discussion, and
we can because I mean, if you look at cervical cancer, way back in the 90s, when we didn't have any great screening programs at that time. One of the major changes that happened was, the education, especially the women's education, was improved by good networking and good use of these health workers, especially in the rural cancer registry like Barshi, where a lot of trials have been undertaken. And you can see how the stage 1 cancers detection has improved purely by educating the public. So the main crisis in current cervical cancer control is lack of awareness. Especially women think that HPV testing is actually detection of cancer, which is not. So a good survey was conducted in Australia where they found out that many of the women who were taught about cervical cancer screening, they thought it is a means of detecting cancer. They didn't know that HPV testing is such a beautiful way of finding out the pre-cancerous states, and gives you a lot of window period, as rightly shown by Dr. Shankar Narayan in one of his beautiful papers. In the lifetime of a woman, you would require only one single test in 10 years. So that's the beauty of the the screening program in cervical cancer, where HPV testing has really reduced the mortality rates compared to VAA or any other modalities. So I think HPV screening with HPV DNA testing would be the order of the day in the future, where visual inspection with acetic acid and all those things would be at the second level only.
Thank you, Dinesh sir.
Dr. Jaman, shall I make one or two comments, if you permit?
Please. Yeah.
Okay. So congratulations, Dr. Dinesh and Dr. Megha for excellent presentation talk. I think both were very informative, and I should thank and congratulate Dr. Joy and the team for selecting the apt topic of carcinoma cervix on this World Cancer Day, because as it was mentioned in 2022 to 23 and 24, the theme is close the care gap. I think cervical cancer is the best prototype cancer which this close the care gap, the importance of that holds good. Because if you see the burden of disease which the speakers have shown, entire world, it's about 85% of the disease, this carcinoma cervix, is in either in developing or underdeveloped countries, and just another 15 or 10%, 20% in developed countries. And why it is happening, it is very clear. Now, the action, what we can do is two important things, which again, they have mentioned very clearly. One is the use of HPV vaccine, which if you take 100 people, we will be able to eliminate 80%. Now the rest 20% of this, if you can detect 80% early by screening, either the best method, as Dr. Megha was talking, it's HPV DNA test, and so together we can eliminate 96 or 96% of carcinoma cervix, which I think which turned out to be like, it's a total elimination of the disease from the world itself. So I think it is possible if all the medical fraternity if you can convince the leaders, the policy taking leaders, the political level, that as in developed countries, we should make it mandatory. We should make the HPV vaccine as a national vaccination program, and we should make the screening program also compulsory or part of insurance system, whatever. So I think this is a best example where a cancer can be completely eliminated from the world itself. Although there are, as both speakers were talking, there are multiple. There is a very development in the science in oncology field with the introduction of immunotherapy, etc. But they are very, very expensive, and that can be afforded only in developed countries only. Yeah.
Just to interrupt,
definitely.
I think to eradicate cervical cancer is a very major challenge, and the only way we can do is with the political will, as you mentioned. If states like Sikkim, as Dr. Megha mentioned, states like Sikkim and Punjab has achieved close to 90% vaccination in the programs, and that is because a lot of political support is happening in these areas to implement this. Countries like Bhutan has taken up in the national immunization strategy. Even a Muslim nation like Malaysia has implemented vaccination strategy. So it's a political will. I think if the politicians are interested, like in the pandemic times, you have seen how the political will has succeeded in vaccinating so many. I think to eliminate cervical cancer, mostly we need that political will. And we can succeed, but it will take a long time if the politicians are not convinced about the need for it. I think we need to push it from that level. And the awareness of the public also. The awareness of the public also is extremely important.
This time I should mention that there is at least one trial from, I think, Latin America, where they have given, it is a retrospective trial where they have used only one dose of HPV vaccine and found to be almost as effective. So at least that we can push in India. What is Dr. Mega can comment on that also.
I think Anil, Dr. Anil, you are right, because if you look at Dr. Shankar Narayan's paper, in the study, they looked at the cohort of children who received only one dose of vaccine. Yeah. And that is actually because the trial closed, due to unfortunate circumstances, the trial could not be continued. But in the time period they analyzed, they looked at the data where the children has received only one dose, and they found sufficient antibody levels. And Dr. Shankar Narayan firmly believes that a single dose is sufficient in the Indian population. And once the Indian vaccine rolls out shortly, and that is a great opportunity for us to try single dose. Yeah. Probably that would be the answer for a good national coverage. In fact, a lot of countries have really taken up the third dose to a different time interval, so that they will know whether the first two doses will be equally effective. So the third dose is delayed in many national, vaccination strategies.
Thank you, Dinesh sir, for answering that question. Yes, I have heard in a talk by him, Dr. Shankar Narayanan himself, about the single dose. And I did not comment on this because we're still awaiting robust evidence.
Correct. I think we hope there will be some off-label approval for a single dose, at least to, for our advantage.
Yeah, definitely that will reach out the popularity of cervix cancer vaccination, definitely. And we all know that it's not the benefit of HPV vaccine is not limited to the cervix cancer alone, because the vulval cancers, oropharyngeal cancers, and anal cancers are all can be prevented by HPV vaccination. So it's offering a wider spectrum, and it's one of the very proven vaccine which we can very safely and effectively used for preventing developing cancers. Okay. I would like to take one question from the chat box. What is a Gallery test, and is it available around? Okay. Dr. Santosh Babu has asked that question. Dr. Meka, you want to answer that?
I'm not entirely sure. Can Dinesh sir take the question?
What is that question? I didn't get it.
What is Gallery test? Yeah, it's a blood test which is presently in under clinical study, which can be used to detect cancers. They claim that nearly around 50 cancers can be detected very early. But from my knowledge, it's not available in India. It's still under FDA approvals. Dinesh sir, Anil sir, any comments about that?
I think they are in Lalpat they are doing.
In India?
Okay. Lalpat. Anyway, we do not know
they are not sending the sample abroad, no? Okay. They're doing.
I do not know about that.
So I couldn't see any other questions here. Is there any other questions from the audience?
Just to trigger a discussion from the clinical point of view, I think a lot of cervical cancer patients undergo inadvertent hysterectomy, and as radiation oncologists, we are forced to give radiation therapy because of So, should we evolve a protocol where before hysterectomy, what is the best way of avoiding these kind of situations, and how best we can, take away this concept of minimally invasive surgeries in cervical cancer, because the evidence from the LAC trial has come out with very negative results from. From the gynecologist fraternity, are there any concrete steps to see that we don't use minimally invasive surgeries in early cervical cancers? I mean, just to kick the discussions and make it more lively, because it's a very when it comes to minimally invasive surgery, the gynecologists are very passionate, and unfortunately in cervical cancer it has not been very helpful. And how far it is being used now, or is it because of the evidence everybody has stopped doing it for cervical cancer? What is the turf?
Well, there was a scare with the LAC trial, but soon after that, I believe there are a couple of larger trials pointing out some methodological errors with the LAC trial. And so the last word on it has not yet been said, I think. But as you said, what every gynecologist in the periphery can do is evaluate a patient fully, especially when they come with abnormal uterine bleeding or postmenopausal bleeding. Do not do a hysterectomy like you would do for any benign condition without evaluating, because even in the past couple of weeks, we had 2 ladies come who had their vaginal hysterectomy done for small sorts of prolapses, but it also happened that they actually had postmenopausal bleeding, which was overlooked. It was not evaluated, and the final report came as carcinoma endometrium. So then we are forced to do a revision surgery where she's subjected to the morbidity of another surgery again for lymph node assessment and all the other paraphernalia. And in fact, you're doing injustice to the patient, because she will you're not evaluating her properly. She's not getting the best initial surgical treatment and evaluation, and it is actually negligence. So it's high time that once, as Dinesh sir said, there should be a proper protocol for evaluation. And then if malignancy is found out, it's best to refer them to centers with experts in the field. And this will do good for not only the patient, but also for this for the treating doctor, because you can get sued.
I think another problem from the radiation oncologist point of view is when we give post-op radiation therapy for whatever indications, the morbidity is very, very high. In fact, there is a good trial, randomized trial from Tata Memorial Hospital, which showed that superior techniques like intensity modulated radiation therapy would confer better small bowel toxicities, and it should be offered as per the protocol. But from the equity perspective, when you scale up the type of treatment in a cancer cervix patient to IMRT, the cost of care goes up considerably. But so that's the point I'm trying to drive, that when you select a patient, you need to select it carefully so that you finish off the treatment with one modality. And that would be the best for the patient in terms of downsizing the morbidity, as well as the financial toxicities also. Jomon, your comments?
Yes, sir. That is correct. Actually, both points are very important. As Dr. Mega said, once you diagnose disease, and then the next step should be a multidisciplinary team discussion, and to properly channelize the entire treatment protocol till it complete. Okay. From the diagnosis point of view, from the diagnosis to surgery or radiation or concurrent chemoradiation. And also, as Dinesh sir mentioned, the kind of technique which we have to use, because carcinoma cervix is more common in low socioeconomic status. So when we have to use the higher techniques in radiation oncology like IMRT and all, it will be very expensive. But that never deny or never hesitate a patient to undergo a radiation treatment, because it's such an effective treatment for carcinoma cervix. And we know the cure percentage even for stage 3 and stage 4A is nearly around 50%. So no patient should go away from treatment just because of the financial constraints. Okay. And is there any more questions from the audience side? If nothing much, we can have wind up this section. I think any more important points to discuss, sir? Dr. Mega, Ranil sir.
Not really. Thank you.
Thank you. Thank you.
When to start chemotherapy? Chemotherapy.
When to give chemotherapy for carcinoma cervix? Is it?
Yeah, that's a good question. Chemotherapy is generally given concurrently along with the radiation for all the disease which is from stage 1B2 onwards. So if you have stage 1B2, when you're offering concurrent chemoradiation, that is the treatment choice. One of the major problems when you treat cancer cervix is the presence of nodes. And when you have a nodes in the common iliac and the the multiple nodes in the pelvis, generally we electively treat the para-aortic chain. So treating the para-aortic chain is quite comfortable in modern radiation therapy practice. So when you use concurrent chemoradiation and para-aortic chain, it's always more comfortable to use better technology like intensity modulated radiation therapy to spare the bone marrow and the bowel toxicities. But you can treat with good conformal 3D plan also with equally good results if you are very careful in your 3D planning with more attention to detail like image guidance and better conformal fields. The problem with trials is when you use intensity modulated radiation therapy, they all go with image guidance. But a 3D plan is never given the advantage of a good image guidance for lower PTVs. So if you really compare a good IMRT with a 3D plan, it has to be given with the weightage of good image guidance in both the treatment arms so that your PTVs can be minimized for the daily setup uncertainties. So that would be a true comparison. Regarding the role of adjuvant chemotherapy, the Outback trial, which was published a few months back, has shown no benefit, which is a bit unfortunate and disconcerting for us also, because we all was trying to find a way for these young patients with advanced disease probably getting a benefit from adjuvant treatments. But for metastatic cancers, we have a few drugs like expensive drugs like bevacizumab, which is being used to some extent for some good local control. Dr. Anil is there. He can comment on that about the futility of adjuvant treatments and the benefits in a metastatic disease with bevacizumab. But there are a few patients getting cured with metastatic disease. So we have to, find out this group of patients who would really benefit from intensive treatment for low volume metastatic disease, or probably we should indulge in trials from our own side to see whether some kind of adjuvant treatment would work in these settings.
How long patient can get survive after confirm of the cancer, cervical cancer, after chemotherapy and radiations, and also hysterectomy? First they got hysterectomy, and afterwards radiations, afterwards chemotherapy. The patient, the possibility of living when metastatics, afterwards back to the peritoneum, it causes in peritonitis. Then the patient survival, just you have to tell the patients how long you can survive.
Correct. I think the survival has improved a lot. For example, when we started radiation therapy practice in the 90s and in the 2020s, if you look at the stage 1 survival has gone up from an average of 70% to almost over 90%. Stage 2 has improved from 70 to almost 80%. Stage 3 has improved from almost 40 to the current survival of around 60%. So with better, treatment practices, concurrent chemoradiation, and the use of image-guided brachytherapy, like with Jacastro guidelines, the tremendous improvements have been possible in getting better outcomes. But for stage 4 disease, unfortunately, it's not very good. It's only around 20 to 30%.
One of our relatives got cervical cancer and hysterectomy and radiations, chemotherapy. Afterwards, she told, "Sir, please leave me alone. I will go and die." There's so much they fed up with treatment. There was so much agony they got with radiations. That time I say, I told, okay, leave it. I will stop our treatment. Expired within 1 week. That is why I am asking.
I think you have given a very subtle message on improvements on primary detection and the secondary care we have to activate in cervical cancer, because we don't have the resources to treat all these patients very effectively when they come with advanced disease. So prevent them and treat them, like the screen and treat programs, which was initiated in Amblikai and Osmanabad by Shankar Narayan and his colleagues so effectively. In fact, it happened in Chennai, not in Kerala, in Amblikai, where screen and treat programs, the nurses were actually trained in colposcopy. That's the beauty of this trial, in the randomized trial, where the nurses were empowered to screen and treat. So whenever you have a CA3, you actually treat it at that point itself with electrocautery and after a colposcopy. So I think those are the interesting ways where randomized trials were conducted in our own backyard with good evidences on screen and treat. And we need to change our philosophy in channelizing our energy in these directions. Tertiary care is always expensive, and it's all loaded with uncertainty. An outpatient will not do well, as you rightly pointed out. So we have to look at the toxicities of treatment also. So better technology is required for reducing toxicity. That means more of cost. The equity also gets skewed by such approaches.
Thank you, sir.
Dr. Kulkarni, I hope you got an answer from Dr. Dinesh. Now, the present scenario for treatment of carcinoma cervix is not that bad, actually. If you look at the stage-wise, the survival and prognosis, stage 1 cervical cancers, patients will survive, will have a complete response and good survival nearly 95% for 5 years. 5 years and more than that. Okay. And if it comes to stage 2, it's the percentage for 5-year survival is 70 to 80%. And stage 3, it is nearly 50%, 50 to 60, depends upon the how aggressive we can go. And stage 4A, it's nearly 15 to 30%, 5-year survival. Okay. So it's all depends upon how we treat and how we manage this patient. And how we manage his symptoms, and also the kind of care we can give. But the real benefit is that it's a very treatable condition. It's a very treatable condition. The only thing is we need to motivate the patients in the beginning. So because some patients in the advanced stage may come with renal failure. It's basically an obstructive uropathy, which we may have to deal with with the help of a urologist, bypassing the obstruction, urethral obstruction, either by a percutaneous nephrostomy or by putting a ureteric stent. And once we stabilize the renal problems, then you start with the radiation and chemotherapy if they tolerate, and they do respond very well, very well. Okay, so the scare of patients regarding radiation and chemotherapy, I think it has gone now, but still it's there. We need to encourage them more, and I think the cancer survivors can motivate these patients much more than anybody. We need to have more survival camps and orientation programs. Of course, the preventive method, popularizing the preventive methods will be the best way to reach out this problem, actually.
And another point which the gynecologist should be aware of is, from the radiation point of view, is the late toxicities. Many of these patients can come to them with rectal bleeding and hematuria many years after radiation. In fact, many of the local doctors get really worried when suddenly the patient comes to them with bleeding, and they are labeled as recurrences. But you must understand that radiation can cause very late toxicities like rectal bleeding and hematuria, which can be controlled to a large extent. In fact, mild rectal bleeds can be controlled with good laxatives and hemostatic drugs. But in a severe bleed, you need to do a proctoscopy and try to fulgurate them, like with argon laser fulguration would be very, very effective. So such simple measures can be advocated in 3 to 5% of the patients who end up with grade 3 toxicities. So managing that is also important, because ultimately the patients needs to get the confidence that even though their disease is cured, these kind of diseases, the bulky diseases, can be cured only with good dose of radiation. And when you give good dose of radiation, you're bound to end up with some amount of late toxicities in a few percentage. But these can be addressed with good local treatments.
Thank you, Dinesh sir. Any more questions? Over to you, Dr. Sharmila.
Thank you, Dr. Jomon. So it was a wonderful session, actually. And I would like to go on to the vote of thanks. Joy, sir, are you there?
Oh, yeah, I'm here.
Shall I go on to the vote of thanks?
Oh, yeah, vote of thanks, yeah.
Thank you. First of all, I would like to start by thanking the faculties today. Dr. Dinesh Mokani sir, who spoke on the challenges in eradicating cervical cancer. We could see that sir was very disappointed that he couldn't share the slides that sir had painstakingly prepared. But that was okay, sir.
Okay.
Such hitches do happen. But then it was nice listening to the voice of experience. Next, I would like to thank Dr. Megha Jaiprakash, who lectured on all that we need to know about Hpv vaccination. Seems we should conduct campaigns for these vaccination campaigns for Hpv also. Thank you, Dr. Megha. And next, I would like to thank Dr. Jomon Raphael, who chaired this session so well and making it interactive. Thank you, Dr. Jomon. And Dr. Anijos, who made this, who had a discussion. Thank you, Dr. Anijos, sir. And Dr. Rengana Kulkarni, sir, who shared his experience with the patient. Thank you, Dr. Rengana, sir. And like Dr. Jomon said, maybe cancer survivors would be the best advocates of this vaccine. Also, thank you, Dr. Joyce Manjula sir, Dr. Gopi Kumar sir, Dr. Jane Chimman, and other members, other esteemed members of IMA and WDW who attended this meeting tonight. That's all there today. Thank you and good night.
Thank you.
Thank you very much. The meeting is closed. Thank you, Dr. Maga, Dr. Jaman, Dr. Dinesh.
Thank you, Dr. Joy.
Thank you. Thank you, everyone.
You all for making it an excellent session. Thank you.